webinar which is there on the platform of ISCCM, and this is about discussion of an important topic which still has clarity issues when it comes to how to practice this in our critical care practice. And this is about understanding end of life issues more so in our setup. What is the status of end of life issues in this country? So this 1 hour webinar will have two talks of 15 minutes each, and then we have a very elite panel discussion where people who are actually practicing it in their routine life, and they understand the intricacy, and we will be discussing certain issues about it. So for the first talk, I would welcome Dr. Srivatsa. He would be speaking on understanding the indications and implications of end of life care. Dr. Srivatsa, please.
Thank you, Sachin sir, for the introduction. So good evening everyone. So just give me some time to share my screen.
Please go ahead.
Okay. So good evening everyone. So today we are gathering here to discuss about a deeply personal and professional topic. That is about, my topic is about understanding the indications and implications of end of life care in India. So it's a navigating and it's a evolving landscape. So before we dwell into the medical aspects, so let me begin with an evocative letter by Constantine Canoris written to the doctors, which offers a profound reflection on the choices we make as a physician. So the letters to the doctors goes like this, and this is taken from the ISCCM position statement. So I was born premature, 4 months early. You intubated me and you put me on the ventilator because you could. It went on for days, and my parents said stop. And the last straw, they finally could. If you had known what my future held, would you listen to me on day one? Would you stop? See, this letter captures the heart of what the most common dilemma which runs in our mind as an intensivist, right? So just because we can prolong life, does it mean we should? This is a very introspective question which we need to all address by ourselves. So modern medicine, with its extraordinary technological advancements, has transferred the care and has also transferred the landscape of how we manage critically ill patients. But as we focus on these evidence-based practices and cutting-edge interventions, we risk losing the art of medicine and the human touch that prioritizes compassion and connection over the mere just outcomes, right? So the push for this measurable metrics, quality metrics, and advanced therapies has often sidelined the patient's living experiences. And with an ever-increasing lifespan and as well as rising burden of chronic illnesses and debilitating diseases, the ICU is often the last stop for patients who may never recover, right? This is a scenario what we generally encounter, especially with our geriatric population. And this brings us to the heart of the topic today's discussion, that is end of life care. So before going to that, we need to understand that we need to merge the evidence and as well as the art of medicine together to bring the new dimension to it. So what is end of life care? It challenges us to balance preserving life. Preserving life with the need to allow preserving life with the need to allow dignified and peaceful death. In India, end of life care is relatively a new concept, and it is shaped by the cultural norms that emphasizes that the life should be preserved at all cost. And till now, recently, even the legal framework was fragmented, but after 2023 verdict from the Supreme Court, it has been a little bit streamlined. And even the other problem is the limited palliative care integration, leaving families and as well as clinicians ill-equipped to handle the end-of-life care decisions. So when should we think of end-of-life care, or what are the indications of it? We all know it, right? It's whenever there is an irreversible multi-organ damage, terminal illness, or whenever there is a persistent vegetative state or brain death, or in refractory conditions, which like most commonly septic shock or severe ARDS, where conventional measures has failed, and then we need to go for the next things, and that patient and family is not affordable to that. So all those things, conditions gets us to consider end of life care. And even sometimes patients and other people do come and tell us to limit the interventions because of the financial burden, most commonly in India. But there are certain very few populations where they have advanced directives. But till now, in my experience, I have not seen much of advanced directives with respect to end-of-life care in my limited clinical experience. The problem is, even though we have all these indications, still we are very poor at recognizing when the patient has to be transitioned to end-of-life care. And that is not even only in Indian scenario, it is even with the Western scenario. If you look at this national audit from the UK, the recognition of death was delayed as long as like 72 hours. I mean, only before 72 hours or before 48 hours, they could recognize that the patient is dying. And delayed recognition and diagnosis results in missing the opportunities. And in one of the systematic review, it is said that almost 40% of the patients nearing the end of life received non-beneficial treatments. Means being aggressive is ingrained in our training so much that we suffer from lack of recognizing this death itself. And that is not only with our case, it's with most of the physicians, because of our own personal opinion biases, or it may be because of the lack of communication skills or lack of ability to prognosticate the patients, or sometimes over optimism from the physician side, as well as miracles on other stuff from the patient side. And it also partially depends upon our willingness to face these moral dilemmas, because most of them we don't want to in our busy schedule. And the self-fulfilling prophecy is another vicious circle which can get us down the spiral and to do everything most possible. And it also depends upon our attitude towards handling the uncertainty and as well as risk associated with early prognostication. So these are all the problems which makes us ill-equipped to diagnose death. And in the Indian, if you look at the Indian context, this is all much more elevated because of the lack of universal awareness about the advanced directives. And the cultural emphasis is that life should be preserved at all costs, as I mentioned earlier. And there is limited availability of palliative care resources even in urban and multi-specialty hospitals. And even where there is an availability, there is a variability with respect to in-hospital end-of-life care policies. And if you compare to the Western world, here it is more of the care or healthcare is more of family-oriented rather than individual-oriented. Because individual, even if he opts for a palliative care services, the society pushes him or her to make sure not to give up and fight for it till the last moment. So these are all the things which makes it much more complicated. And even in our medical training itself, we are trained in such a way that it has to be all aggressive and you need to do all possible interventions and everything has to be done. And even when I was in the training, I was like, if death is happening, you need to tube the patient, and every dying patient should have a tube down their throat, and then only they should die. That is the concept which has been ingrained. But luckily, in 2024, the ISCCM and IAPC has brought in this position statement, which is more centered on human principles and more of family and patient-oriented care. And that has more streamlined the indications further, saying that there are certain trigger points for end-of-life care taking decisions or initiating the discussion about end-of-life care. Like whenever a patient is having a catastrophic brain injury, where there is a massive stroke, the recovery of meaningful neurological recovery is very less. Or in patients with critical illness on a background of chronic irreversible disorders, or critical illness on a background of irreversible neurological disability like traumatic quadriplegia or end-stage neuromuscular weaknesses, or in patients, as we already know, advanced or metastatic malignancies, or in patients with advanced age with a declining functional status. The list goes on. And the last one is where there is a surprise question. If you think that the patient is going to be alive, if you don't think that the patient is going to be alive at the end of 6 months or 1 year, then you should think of considering the end-of-life care. So this is all about end-of-life care. But even then, uncertainty still exists because it's not that simple decision which you can just take it up based on these trigger points or based on the indications, because as beautifully illustrated in this end-of-life care pathway by the ISCCM and IAPC's thing, the physician has to be reflective on these prognostic assessments of whether the potential life-sustaining therapies are inappropriate. And this can be brought out only by involving the subjective and objective data. Means no single scoring system will help you say that this patient is nearing death. You need to include everything. And along with that, you need to include even the patient's family and patient's relatives' wishes. And together, you need to consider going into the end-of-life care approach or discussions about end-of-life care. So the indications is not exactly that this has to go into this thing. It's not like mathematical 1 + 1 = 2 and then, okay, these indications are there, you need to go. No, you need to involve the patient, you need to involve the family, you need to involve the colleagues, and you need to come to the conclusion. That's the reason it is like a shared decision making. It's not a one person's pathway. Everybody has to be involved, and then you need to make it a combined decision and then approach the family for the end of life care decision. Once you have done that, the implications which comes out from the end of life care are multifactorial and multidimensional. It includes patients, it includes the families, it includes the medical team as well, especially in the Indian context. And even there are a lot of ethical, legal nuances influencing the decisions. Though end of life care pathway and everything good brings most of the positive implications because it allows for a dignified death, and it empowers even the families for the informed decision, reducing the uncertainty and everything. And it gives the autonomy back to the patients so that they can decide what has to be done further. But again, it also comes with some other implications, which is, I can't exactly call them as negative, but we need to be well aware of those things before we jump into conclusions. So in that, most important is the family implications. Most of the families are not prepared, especially when it comes to death. Nobody comes prepared to the ICUs being prepared that, okay, my loved one is going to die, right? So that brings a lot of emotional distress, and as well as when these things are not addressed in a proper way, it will relate to post-intensive care syndrome for the families, which they need to grieve for longer time. And with India being not having much of a proper bereavement care, this goes on for a long time, and that influences their further lifestyles as well. And even the conflicting opinions between the treating team and the family can also put a lot of distress on the family, because they may be feeling withdrawing of the care can be a guilt feeling to them. It happens. And even the cultural and religious expectation also on the family is very much, because from the childhood we have been trained that you need to do everything possible, you need to do everything, otherwise you are failure. So that is all the things. And the financial burden which all these things brings is again multifold, because most of the families don't have proper insurances. Even if they have insurances, those insurances companies sometimes doesn't cover for palliative and hospice care or even home care. So all those things brings a lot of financial burden to the family. And legal implications has been sorted out with the Aruna Shanbag's case. At least it has paved the way for end of life care in India. And in 2018 was the first Supreme Court judgment which has legalized the advance directive, but it was much more cumbersome. And in 2023, it has been much more simplified. I mean, execution of advanced medical directives has become much more easier, and even withdrawal of life support has been much more streamlined. And there is no need for the jurisdiction has to be involved at the earlier stage. Does that in the current guidelines they just say that it has to be notified. But despite all this legal advancement, ambiguity still persists in practice, and it is because of the lack or inadequate awareness among the clinicians and families, even at the operational levels and organization levels. I come to those things as well.
Dr. Srivastava, only 2 minutes.
Yes. And clinician related implications are also a lot of things like emotional burnout, the moral distress which brings on to that. And most important is the communication challenges. Most of the physicians are scared to even occur the word death whenever the patient is about to die. And even the fear of litigation also, and the ethical dilemmas associated with that. And as I already mentioned, the financial implications are also a lot, because patient and families has to spend out of from their pocket. And social and cultural implications are multifold, because of lack of proper awareness in social media, the end of life care and other decisions may be perpetuating misconceptions about this practice, and that will eventually lead to lack of acceptance. And even death is seen as a failure in the healthcare system rather than is an inevitable outcome, leading to unrealistic expectations. And in Indian belief system, patients and patient family believe that miracles happen, some divine interventions happens, even though we try to counsel that it has happened in real life. We are told that the patient has been brain dead, but even then the patient family hopes that some miracle will happen and he will wake it up. And astrology and all those things comes up into these things, and it complicates the end of life care decisions. And there is a lot of diversity in belief, because Hindu systems believes that karma is an important thing. So they feel that the suffering has to be continued. So all those things. And coming to the organization thing, resource strain is there, and there is no proper training, structured training with respect to palliative care. and there are policy gaps, and the ethical committee, even though it is there in most of the hospitals, it will be either poorly staffed or inactive in most of the smaller hospitals, and peripheries it is much more worse actually. And these are the contrasting things with respect to India and Western practices. But there is a way forward, and there is a light at the end of the tunnel. All these things can be overcome by proper education and training, and having a public awareness, and policy reforms, and improving the infrastructure, including the palliative care services in the ICU and as well as communities, and increasing the research and advocacies can make these things much more better, both to the family, healthcare, and as well as patients. So with that, I would like to say thank you. Thank you for the opportunity. I hope I did not take much of the time. I was a little bit fast.
Oh, no, you were right. Yeah, Dr. Srivatsa, very, very well, said that you have covered almost all the important implications that an end of life decision takes place, right from the patient's end to the society to the legal and the organizational issues. Very well covered. Now we'll move on to the next talk, and this is by Dr. Sai Ramadevi, and Dr. Sai is there, right? And the discussion would be on how to approach a family for end of life discussion. How do you counsel a family? How do you break that news, bring this topic in discussion? So Dr. Sai, you can please share your slide and start the presentation.
Good evening, everyone. I'm Dr. Sai Ramadevi from Apollo Hospitals, Visakhapatnam. Just a minute before I share the screen.
Yeah, make it full screen, please, and just start it.
Can you see, sir?
Okay. Yeah, we can. Please start.
So this is a case scenario. I'll present with a case scenario, sir. A 65-year-old female, known case of AML with relapse on chemotherapy, being well until last 2 days, presented to ER with upper respiratory tract symptoms, unrecordable BP, resuscitated, shifted to medical ICU with high vasopressors. This is a case of neutropenic sepsis in multi-organ failure with disease progression. In spite of all the best efforts, her condition deteriorated over the next 2 days. So here, you never get a second chance to make a lasting impression. So how do I go in this case? Whether to continue with the treatment or go with explaining the patient's attendants or the family members about the end of life because the prognosis is bad? Or how do I go about this case in the ICU? First, as a physician or as a critical care specialist, I will go for, is it an inappropriate life-sustaining treatment that I'm dealing with? Yes, my tick box is yes. Then I would ask the primary medical board, if it is already there, wherein it is comprised of 2 other physicians or any other doctors with more than 5 years experience, to come to have a multidisciplinary meeting and come to a conclusion about the care of the patient. If there is an advanced medical directive or directives already written or there, then I will follow the advanced medical directive or the patient's directives or any surrogates who we have identified. And the multidisciplinary team will be held and a consensus will be obtained, and the same will be referred to the secondary medical board. If there are no consensus or a difference of opinion at any point, the continuation of the full supportive care will be continued. If the approval by the secondary medical board has also been obtained, you send the letter to the district judicial magistrate of the first class and continue with implementation of withdrawal or withholding decision and address all the physical, emotional, spiritual needs and grief bereavement supports, and you assess the quality at every point of the care process. This is as per the ISCCM position statement. But will the things go like this everywhere? What happened to my case and to the same case in the ICU? So how do we approach in this case? So I thought, okay, there is a care pathway. I can follow this as per the pathway. Then in this case, patient cannot make a decision. There is no advanced medical directive. Family members are in a phase of denial. So what do I do? Because the family members are in a denial, I have to continue with the care till she breathes her last. Should I leave this here? No is the answer. So whatever you do, you never forget the ethical principles of autonomy. It is the right of an individual to make a free and informed decision. Beneficence. The patient is the prime, or the whatever the best interest of the patient has to be done. Non-malfeasance and justice are the pillars of medical ethics that you should never forget. So how do I go about in this case to assure that we are with you till the end? Make it clear that suffering together is of no good purpose, and the principle of acting in the best interest is adhered to. And goals of death, wherein you address all the components that help to define good death. It is always a multidisciplinary approach. Can you hear me, sir?
Yes, we can. Yes, we can, Dr. Sai. Please go ahead.
Yes, sir.
What happened? You can continue, Dr. Sai. We were able to hear you.
Okay, sir. Sorry for that. So it is always a multidisciplinary approach. So what are the constituents of good death? Effective communication and relationship with healthcare providers. How you communicate, how you maintain the relation really matters a lot, which I've seen in my ICU. And performance, you give preference to all the cultural, spiritual, and religious rituals. And you aim at relieving their emotional distress and psychological stress. And never forget, autonomy is the prime most important factor. Dying at the preferred place, not prolonging life unnecessarily, and awareness of deep significance of what is happening to both me and to the patient, and emotional support from family and friends, not being a burden to anyone, and you should address all their physical pain and other physical symptoms. The right to terminate one's life. All these things, they are the constituents of good death. What are the prerequisites? They've denied. And how do I go? Again, I know my goals, and I'm with the goals, and I know what are the constituents of good death, and I would like to give my patient a good death. The discussion should start early and not just before dying. Any expression by the patient makes it better and easier. You should know what the patient wants before she has become sick or during the process of her sickness. We should ensure that we are speaking to the correct family member. Identify the right person as per the patient or the next of kin as per the records. Prepare for the meeting by ensuring that the whole team are informed and should agree that the patient is nearing the end of life and are in agreement about the future care. All the team members should be on one word or have a common care plan, and there should not be any difference of opinion. Then all conversation should be held in a quiet, private place. Decision about whether patient should be included in the conversation depends on the patient's wish. And if, in my case, the patient is unconscious or unresponsive, so there is no point involving, or you can't involve the patient. And autonomy, you have to respect that, and you start by formally introducing and affirming confidentiality in the family members. And you assess the understanding of the patient's condition by the family members and their emotional state at every step of your discussion. Then they're still in the denial phase, and you need to breaking of the bad news of the conversation has to be followed if they are unaware, or they seem to be unaware of the serious condition of the patient. And sometimes they are aware of the seriousness, but they don't know that the patient may die at any point. And you should be very cautious of your language, and phrases like, I am worried, softens the conversation. There are n number of phrases that have been given in the ISCCM guidelines, and these are some of them. Like, you can say, instead of saying we can withdraw or withhold care, we do not stop caring, we will only stop or not start a machine that is not going to help, is a better way of telling. There's nothing more we can do. And in this situation, we can do whatever is best for relieving pain and suffering, make it easier for him or her in the last phase. And many of the times I used to say, it is your option to opt for to continue or withdrawal of the life supports. But of late, when I'm going through this ISCCM statement, then I've learned that it's a very wrong way of talking, and tell the family the decisions for the patient is being taken together, only thinking of what is best for him or her. So we'll jointly sign the decision. These things will give them a lot of comfort and assurance, and they trust you, and they may agree with you when once they're convinced. So this is the Spikes protocol, and many other protocols are there, wherein you assure that you have a good space with no interruptions, and the perception, that is, what is the understanding of the patient or the understanding of the patient situation by the family members, and obtain patient's permission to continue, and you assess the knowledge and periodically update regarding the family about the patient condition. You address all the emotional components, and you summarize, reassure, and strategize your next steps when applicable. So this is a study that is published in 2022, which was conducted in the 32 ICUs in France, and a 3-step support strategy for relatives of patients dying in the intensive care unit. A clusterized randomized trial has concluded that among relatives of patients dying in ICU, a physician-driven, nurse-aided, 3-step support strategy significantly reduced prolonged grief symptoms after 6 months, and post-traumatic stress disorder is also low in these patients with a 3-step approach, wherein the patient, the physician, the nurse, and post-death also you address the family's grief.
Dr. Sai, 2 minutes, please.
Yes, sir. So how do you plan? You ask, listen, and listen, and listen. That is the principle, and clarify their doubts. So usually when I was dealing with this, they will ask, how long will it take for the death? Nobody can tell unless you go with disconnection or withholding or withdrawing of care. Some may not have the concept of suffering or unaware of end of life. So it is on our burden to tell them. De-escalation, or they have the guilt, which again we have to address. Can we manage at home? Yes, you can manage, and you have to train them. No de-escalation of care, but restriction of certain supports like RRT. Yes, you can go ahead with them, but it is always all or none phenomena. Can we move towards to home or to other centers? Yes. And how about pain and other symptoms? You can address them. How about family members visiting the patient? Yes, you can agree on that. Music, feeding, prayer by religious head, yes, acceptable. And request for particular date and time, yes, again, it is acceptable. And what will be your decision if it is your family member? I do the same as to your patient, to my patient as to my family member will be the answer. So there will be specific tasks of religion, spiritual, and cultural aspects which you need to address. And it's an spiritual aspect is never, it is always unaddressed issue and a key indicator of comprehensive healthcare delivery. And many studies have showed that there was a significant improvement in the grief of the patients with spiritual involvement or spiritual care provider. And the grief and bereavement support is also required, and the presence of physician at the time of death, education of the caregiving team, and opportunities to address queries, and the complicated grief can be reduced through thoughtful care and good communication. So these are the various aspects that you can address, like the thirst, pain, nausea, delirium, anxiety, constipation, and lack of sleep can be addressed. And again, the important aspect is your documentation and documentation. All multidisciplinary family meetings, final consensus, and PMB and SMB should be recorded in the case notes with signature of team members and family members. And you should have a standardized formats available in your ICU. And you document the time, date, person, and medical details leading to decisions, including prognosis, statements of the patient wishes, and treatments to be withheld or withdrawn, and treatments to continue, and whether organ or tissue donation has been requested, and signature of the family members and legal proxy. And this is the summary that what you're supposed to do at the first meeting, and the subsequent meetings where you tell and ask, update status, and allow expressions of concern, and summarize and way forward, and use of spikes protocol for breaking bad news, and EOL discussions and decision makings along with documentation. So end of life is always a tailor-made, patient-centered approach. Moving from fear of death to accepting death as a journey's end. The secret is to become free by evolving beyond the web. And in this case, I was successful in converting from a phase of denial to acceptance of end-of-life care. And with the documentation, we have discontinued the care for this patient. Thank you.
Thank you, Dr. Sai. Very well presented on how to approach a family when it comes to this decision, because it's not a simple decision. It's not about a decision where you have standardized protocols on how to treat and how not to treat, and this is an emotional discussion where you have to have the family in confidence of what you are saying for the patient is in the best benefit of the patient, right? You can stop sharing your slides, please. Yeah. So moving forward, we will now go on to the panel discussion about the end of life care, and is it really possible to implement the end of life policy as a part of the important policy in your hospital or in your institute, and can we implement this world in the entire country? Can we be more safe in talking and practicing about this? And for this I have a group of panelists who are actually experts in this field, with Dr. R.K. Mani being there. We all know his work when it comes to end of life discussion in this country. We have Dr. Anuj Clark, Dr. Rekha Das, and Dr. Urvi Shukla as well. So without wasting much time, I would directly go to the question format. And Dr. Anuj, I want to ask, what do you think is the understanding of end of life within the medical fraternity? Leave apart the critical care per se. Even in critical care, how do doctors understand, what do they mean by end of life care?
First of all, when I am interacting with our colleague from our specialty as well as other specialty, there is a lot of confusion between brain death, end of life care. They are still have misconceptions about euthanasia versus end of life care. That ignorance is driving the fear amongst them. That's the main word I would like to emphasize. They are not aware of the recent proceedings, what happened in Aruna Shanbag's case. Whatever comes in the newspaper, they know, but they know only partly. And that's why it's their perception this still is that the DNR is illegal. Family will sue us if we do this. If we withdraw, then it will that the patient has died because of our withdrawal of care. And end of life care is being seen as lack of treatment or abandoning the patient because recovery is not possible. These are the misconceptions prevailing in them, and that requires urgent rectification.
Yeah, even I feel so. And I feel, let's say this is a surgical patient, a post-op patient who has, become sick and now he is on multi-organ support system. And then you say this is an elderly patient, probably underwent a surgery. And if you start discussing end-of-life care, the surgeon would say, no, the attendants will take it as my failure, my complications. So please don't talk end-of-life care. Right?
Yeah.
Any comments on such a discussion, Dr. Anuj? Have you experienced such a discussion?
Yeah, it is that again, that means that we need to educate our colleague before we even go and talk to any family member. They are of the apprehension that it is failure on my part or my treatment has failed, my surgery has failed, and that's why we have reached to this point. And I think Dr. Rama has done very nice word that we consider it death as a failure of treatment rather than it's an eventuality at some point of time. So
Right. I
we
totally
need to
agree.
discuss with the colleague of ours of whatever specialty that you tried your best, you practice the medicine as per the book. This is what you and me can do. And I think this word comfort them the most. We have to remove the apprehension from their mind before we actually find a consensus among the treating team, because my colleague has to agree that now in a case of oncology patients, unless my oncology colleague says that yes, I have done whatever is possible, without that I can't move to next step. The same thing is for cardiac surgery or respective branches.
Right. Very well answered. Dr. Rekha, I would like to know from you, what do you think are the myths and the reservations among the community? Because, see, medical fraternity, we understand, we can still explain them in medical language and the nuances. How do you handle the community? They have their own myths and reservations about whenever this end of life discussions happen, that what will happen. So, for example, in Haryana, people talk about reincarnation, right? So if I don't do this, this will happen in reincarnation. Now you can't fight that belief. It's very difficult to make them understand and explain the meaning. So what do you think are the basic myths and reservations that are existing in our Indian community?
The most important, actually, what I would find is common to all people is the emotional distress, the emotional acceptance, the emotion that is attached with the patient that they are not willing to accept, the denial mode, that their patient has gone beyond a certain stage and cannot be revived, cannot be brought back to a normal, as a normal human being. So that is the emotional aspect is the most important thing that creates a series of repercussions, what we see, what we experience in our day-to-day practice. Besides, there are people also who may not have been communicated as the initial core team, the family members. They sometimes come in because these people, the family caregivers, they try to involve those new people who they think are knowledgeable, I have the wisdom to understand when we are explaining them about the end of life care. And when they come in, they create like lot of conflicting ideas come, and that creates a barrier in while you are communicating with the patients. And moreover, see, India is a country where we are not away from superstitions, we are not away from myths, and then they think that miracles can happen. They still are in a denial mode and they think that something miracle can happen. So you should continue with the treatment, not stop the treatment. This is the major resistance that we feel that we are facing in our day-to-day management of end of life care. Plus, The most important, another thing, I do not know whether you or any of you have experienced, the initial that early symptoms have often been missed by the family members. So when they come into the ICU, they say, my person was walking into the ICU,
Exactly.
absolutely fine, and then suddenly you say that the patient has become very sick and all. So that, in addition to the emotional, they also find it very difficult to accept, because they have seen a person walking into the, or being steered in a wheelchair into the ICU, and then this sudden thing that has, the biology of the patient has changed inside, is very difficult for them to accept, or for us to also explain. So we need to have real counseling for these kind of patients, particularly what Dr. Sai said. The patient was receiving chemotherapy, but then the primary physician should have said that anytime your patient can succumb to any chemotherapy, particularly when you are in the second line or even in the third line, and then you sometimes do not have even a day to counsel your patients. When they come into the ICU, the BP is totally refractory hypotension. Patient cannot be revived, and it takes, particularly in my ICU, I've seen patients coming, they have taken chemotherapy, and in the morning and in the evening they come into the ICU, and suddenly early morning they are dying. So it's very difficult. You don't have the time to counsel them also. So this is the job of our primary physicians, to counsel this patient. So this is what makes a community very difficult to sometimes accept this kind of end of life situation.
And yeah, Dr. Urvi, Dr. Urvi first, please.
Yeah, so I think Dr. Rekha has mentioned all the points, but I would also like to add that there is also this fear in the family that maybe they are not giving enough trial of treatment. Maybe they are hurrying up on the decision of end of life. So sometimes they ask for more time. And then obviously there is a balance that needs to be drawn, because every day in the ICU will cost them money. But then at the end of which, so they will keep pestering the ICU doctors, what do you think? So any doctor that they see moving in and out of the door, they will catch hold of them, they will try to ask, what do you think, is my patient getting better, should we continue, should we not continue? So I feel at that point in time, when they are asking for more time, it is very important that the entire medical team, the treating team, works in unison, because otherwise it creates a lot of issues. Like Dr. Rekha has mentioned, that the patient comes in the afternoon, there has been no continuity of counseling, and then suddenly they come after an chemotherapy, they deteriorate, and overnight they have died, and it becomes even difficult you don't get enough time to even counsel these patients. So I think asking for time is an important issue.
Dr. Anuj, you wanted to add something?
Yeah, I think 3 sentences. First of all, doing everything every time is not optimum, needs to be explained. Sometimes limiting the care is also optimum. And who will decide? Again, the same treating team. Number one. Second thing, the misconception should be removed that if they sign limitation of care form or the direction of care form, then my insurance claim will be rejected.
Yes.
Third, they have misconception that in medical legal case, my case will become weak if I sign a DNR consent. These are absolutely wrong notions, and I think that we might have to even take a lawyer's perspective into this place, because this misconception need to be removed. In fact, one of my patients said that at the time of signing the DNR form, he said that I feel like I am signing death warrant of my father.
Yeah.
Now these are the words that really, it is bugging me since last more than 1.5 decade. And that's why I keep on uttering people that don't consider you are giving optimum care. You have bestowed the trust on us that what is best for your patient at this point in time. And we will do to continue to care. Only the manner of care, the direction of care will differ. So we are not abandoning, we are not stopping treatment. We will continue optimum treatment, but we need to explain what is optimum at this stage of life. And I think these 3 conceptions are important.
Dr. Rekha, do you think this end of life care decision is directly associated with the amount of payment that the patient is doing?
Yes, definitely.
Because let's say if this is a panel patient, they may never think about an end of life care versus a patient who is a cash paying patient.
In government, where the government is paying the money, the government is paying the entire money in our cancer hospital, the government is bearing the entire cost. and they don't want to take the patient home because there is no provision of insurance coverage or the
Exactly.
government coverage at home. The domiciliary treatment is not covered at home. And plus, it is also a physical burden on them. The social problems are there of who will be taking care, because they probably have to have some lost business hours and all. So those things are very important we need to think of. But in the corporate, where I also am attached to a corporate, there they wouldn't mind taking their patient away to home, because basically they are paying for every day and they're not
Yes.
going to get back their patients. So the thinking process changes, how you are paying the patient or how you are involved with the patient. So that definitely has a very important aspect of accepting the end of life care. Those people are in a better, they're more wisdom, have more wisdom, and they're better able to understand what is end of life care, and they are able to like kind of coordinate with us, and they are the people who should be the stakeholders in creating the awareness for end of life care, I think.
Mani sir, you are the flag bearer for this, end of life issue when it comes to our country. So I would like to understand what is the present legal status that we all as clinicians should understand, that who can sue us, who can't sue us, what can we talk, what can't we talk, what can we do, what we can't do in terms of when it comes to end of life care.
No, firstly, I think this legal issue has been overemphasized. The main issue is the physician himself. We have so many reservations about our very ethical and correct, standard action. Right? Standard action is what prognosticate as accurately as possible, as honestly, as bravely as possible. If there are emotional reactions, then support them. Support them through the process of acceptance, because these are not immutable conditions. Okay, they're emotional reaction, but that doesn't mean the emotions can't settle down. There are difficulties in understanding. That doesn't mean we can't overcome them. We are doing that for interventional, aren't we? That also involves emotions. If you are going to operate, it does upset people, but we go through. So similarly, I think our perspective has to change. When some intervention is not likely to make a difference or going to harm, you should be able to state that. Whatever be the final outcome, the process has to be there. Process is centered on the patient interests. So we must communicate effectively what is in patient's interest. Whether or not it's going to culminate in a withdrawal or withholding decision, that's a different matter. Now, there are people who have been made aware of what the facts are and what the rights of the patients are. You see, more than the legality of these actions, what are the rights? That there is a right to refuse any intervention.
Agreed.
And that persists even in a patient who is not compos mentis, who is not capable. That is what we are talking about. That is what the legality is about. Now, where we placed a lot of importance to law was we wanted to duck these issues, okay, which are complicated, which are challenging, ethically challenging. Now we want to shift the blame to lack of law, but then law is there. It is stated very clearly that we have the right to refuse, and the right to refuse is can be implemented in a incompetent patient through a process, and that process has been defined. It was very onerous process in 2018, but in 2023 it is now doable. It's still a bit difficult, and there are elements of the process still incomplete in the structure, but you can take the principles. The principles are withdrawal and withholding are not euthanasia. They are correct, legally valid decisions in the medical world, and it is number two principle is it can't be done unilaterally. It's got to be a collective decision. And number three is you have to do it taking the consensus of the family. So legal status is very clear. These are legally valid. Now, no point going back, confusing the whole thing again with confusing DNR with suicide and confusing DNR with euthanasia. All this is uneducated opinions. Now, lot of people do have uneducated, but people have got educated as well. This is spreading awareness and knowledge, and is spreading. So we must offer to the public whatever is available. There may be takers, there may be no takers, but then a few takers, they are the low-hanging fruit, and they start a process. So when you are starting a process, we don't wonder how many people are going to accept.
Yes.
Already in the last 20 odd years, even without a law, I've been able to practice a lot of it. Okay, even before the law, all this has been practiced. We have been taking collective decisions. There has been an oversight committee. In Artemis, we started it in 2010. And then we were able to implement withdrawal of ventilator. Now, when you don't know at all that these things are possible, then people assume various things. We assume that it is not, people are only interested in money. Not at all. There are people who are interested in suffering. And that we are aware of, and suffering doesn't escape any person, whether they are able to afford or not afford. And even the affording, we have been able to implement withdrawal and withholding, even with third-party payments. Because let's understand, even if it is the government hospital or third-party payments, we are the ones who are paying ultimately. It's a resource misutilization. And knowing this, we want to go with the flow and don't want to voice a contrary opinion. It is our drawback. Okay. It is our individual drawback. It is not of the community. It's not of the society. Now, we belong to the society and we know its drawbacks. So we have to act accordingly. We have to address those drawbacks rather than use it as an immutable barrier. So the legal status is very clear that these can be done in a collective way with two panels. Now, the first primary panel can come from the treating team itself. All it needs is the primary physician and two other physicians with 5 or more specialist experience. Now, this is what is usually happening in the critical care scenario. More than, usually 3 or more physicians are involved in the care of a critically ill patient. So you can easily put it. The primary medical team is already there. Primary medical board is already there. So that they engage the family in a candid and sensitive conversation, which involves clear reflective prognostication and waiting for this to sink in, to be understood, taking them through the process of denial and then to acceptance, because denial is not a final immutable destination. It moves on to progressively to acceptance. That's what we all know as, in psychology. So and this may not take a long time. This may take just a day or two. So we go through that. Then if there is an agreement on a treatment limitation decision, then we present it to a secondary medical board, which involves one CMO appointee, RMO, and 2 other physicians other than those who form the primary medical board. Now we can, in theory, and there is nothing against it in law, we can have all the 6 physicians from the same hospital. We can have a standing panel of RMO appointees, so we don't waste time. And the Supreme Court has also directed that the secondary medical board must opine within 48 hours. It can be any time within the 40. So if you have a system going, then this can all happen expeditiously. As of now, this is doable. Now, since we don't have informed CMOs who will appoint RMOs, this process is going on as of now. We are working with the Ministry of Health and Family Welfare. What we have done is informed all the high courts of the states, and the high courts have informed the health ministries of the states. So the directive has gone from certain states to the district magistrates and eventually to the CMO. Now, this process is on, and it is the physicians who, through their practice, will accelerate this process. And now, with the Ministry of Health guidelines also being published, it was uploaded for public comments in September. Now, the final form will be ready, and these are the essentials in the government guidelines also. So, since the guidelines are coming from Ministry of Health directly, I would expect this to get implemented as well. So, watch this space until we have CMO appointees. We can practice as we are doing. We can have two panels, one primary board and secondary board within the hospital, and document properly and implement. Yeah.
I agree, sir. It is just the misinterpretation or probably misinformation about it which creates all the confusion. Dr. Urvi, do we really think after all these efforts, the ISCCM has taken out its position paper? There have been a lot of publications. The Supreme Court has given a judgment, and now the preliminary draft was uploaded. Are we still moving towards a positive impact of implementation? Do you think that this will become a reality in near future?
Yes, I think very much it will be a reality for the fact that in certain socioeconomic strata, the life expectancy has matched Western levels. Secondly, we are dying less and less of infectious diseases, and we are dying more and more of chronic ailments, lifestyle diseases. And then there are going to be not just malignancy or cancer patients who are terminally ill. We will also have patients with organ failures who are terminally ill. And this is going to be a policy that will be a lifesaver. If we take a poll now, I'm sure at least 30% of us will have one family member who has been through this process. So speaking of myself, I have had my father-in-law and my mother now who's very severely demented, and she's completely bedridden. So this policy will take off. It is only a matter of time, till the hospitals kind of start rolling in these policies. And like Mani sir has said, that the low-hanging fruit, we have to be the torchbearers. So I have a very positive outlook towards end-of-life policy being implemented in India.
So, and do you think that if for these chronic, as you said, people are dying more of the chronic conditions as compared to the more infective conditions nowadays, right? So these chronic condition patients, when they come to their primary physicians, if they start counseling during their OPD visits and other visits, that see, this is the progression you will see during the disease, and at some point of time you will land up into ICU with this condition, and we should think about it. If that education starts very early in the journey of a patient who is chronic, suffering from a chronic comorbidity, will it help in faster implementation or faster acceptance of such a policy?
Absolutely. I think patients are asking about their future. They are asking about how the illness is going to affect them. They are asking about how long do I have to live, because there are adjustments to be made. There are things to be set for their children, for the spouse, for the family, other family members who they may be carers for or have responsibility for. So these things are definitely happening, and the earlier we are able to speak to them about, obviously each person will have a different trajectory on when is going to be the right time to initiate this talk of treatment limitation. But the earlier we are able to speak, and the primary physician starting this discussion definitely will help. And now with advanced directives that have come, which are easy to implement, and you don't need a judicial magistrate, you just need to intimate them that you have done this, and that is definitely going to help. Especially there again, there will be a class of population who will very eagerly go ahead and do it, and then there will be some who are trailing, but you need to capture the low hanging fruits. Definitely.
And this question I would be putting to the entire panelist: who all should be preaching about EOL when it comes to wider acceptance? Who should be that torchbearer, apart from, let's say, we understand that we see these patients more often than any other specialty, but apart from us, who all should be that person or that specialty who we think should be preaching about EOL?
I think
Manisa?
I think all of us, I don't think that, this has got such wide reach that it is both professional and and non-professional, thought leaders should be talking about it and spreading the awareness. Now there are
So
a
should
lot
it
of
be
people
only
in
the
the
medical
community.
fraternity or apart from medical fraternity as well?
Both. I think both are required. In fact, nowadays, you see, there are people, NGOs who are in it, who are looking after, for example, cancer supporting NGO, or those involved in the care of the elderly, geriatrics population. The caregivers, non-medical caregivers, they are closely working with dying patients, and they
Right.
can spread the word. Some lawyers who are involved with us in this endeavor, now they are spreading the word. Okay, all lawyers are not the same. Lawyers were quite convinced about what we are doing, and we are seeing eye to eye. And in fact, in our position statement, there is a lawyer involved, and there's a whole chapter. Chapter 10 is written on the legality, is written by a lawyer, Dr. Dhwani Mehta. She's a PhD in law. That's how she
Right,
talks.
sir.
So I think this belongs to the community, because everybody is going to face death, either with one loved ones or oneself.
Right.
So this reaches everybody. It is because death has become so medicalized. Medical people are in the forefront, but eventually, in the fullness of years, death should not be medicalized. Okay, there's a lot of hospice movement since the 50s and 60s in the West, and that is taking over 30% of the care of malignancy patients in the West. And this is just started with us, the hospice movement. Now, those who set up and run hospices, they are also part of this campaign. So everybody who is involved in the humane care of anybody who is suffering should be an advocate for end-of-life care, appropriate.
There is a question which has been posted is, who can authorize DNR, as in who can sign the DNR on behalf of the patient? Should it be the spouse, parent, kin? Legally, who is the...
No, legally, see, it's the same. DNR is only a withholding decision, withholding of CPR. It has not got any other special status. So the same process, if the patient can himself authorize, then that is best. I mean, then there is no process. So patient has the right to refuse anything. CPR is a medical procedure. It is not imperative. It is not a default procedure for anybody. It has to also have indications, and it has its contraindications.
Right.
When it is the way death occurs. No, when you just do CPR, it is meaningless. It can do harm. Firstly, it deprives the death of dignity, and secondly, you may have hypoxic brain injury and have fate worse than death. So let's understand, DNAR is nothing more than another withholding decision, the simplest withholding decision, because only CPR is being withheld, not other things. Right. So that is
the new guidelines.
Decision.
Yeah, the new guidelines which come up, they remove this confusion about passive euthanasia and other stuff, which was
yes,
once
we have repeatedly tried to remove, even with the in the courts, we have tried to remove, but they have that passive euthanasia is stuck, unfortunately.
Yeah, by
that's a misfortune. Now there's an ICMR definitions document. There it clearly says passive euthanasia is outdated and it doesn't convey the meaning properly. Withholding and withdrawal is what the term we should be using, medical people.
I think very well said. I think from this platform that it's not that everybody should die with CPR, failed CPR only.
Not at all.
It's like that.
In
it's
fact,
like
in the ICU, only 5%. Only 5% should have received CPR.
In our cardiac arrest registry, out of 2,000 patients, 114 had DNR in place. So no CPR was done in 114 out of 2,000. This is the data from our own registry.
That's like 5%
I think that's the beginning of the era, I would say.
At least we do have some.
Yes.
Until some time ago, there was CPR was 1%.
I think our oncology colleague and our palliative care lack of ability of palliative care has really affected this decision a lot. because say everything now, palliative care is also very intensive as far as intensive nursing is concerned. It takes a lot of nursing steps. So people feel that my loved one will be neglected the moment I said DNR or direction of care,
Yes.
and that has actually happens. And
No,
I'm
that is for us. That is for
that is
us
our
to
imperative to
correct.
avoid it.
Yeah, it is our call to tell them positively, affirm continued care, and to practice it also, so that we carry conviction.
Right. So we are up with time, and thank you all for such a wonderful discussion, and talking about issues uh, where there's still a lot of gray areas. People think otherwise. The implementation and the understanding of the law and the policies are still not there. It will still take time. We are en route there, and I think in next couple of years probably we will have a strong and a solid policy where people will not be afraid of talking the word death or an end of life care, very commonly for comorbid patients, for patients who are actually just being stretched on a ventilator or life support because nobody wants to touch this discussion, right? Thank you so much for being here, and we'll end the discussion here itself. Dr. Gunjan, you want to say something? Is she there? Dr. Arif is there. Dr. Arif, you would like to have closing remarks?
Thank
You're
all of
muted. Yeah.
yes.
Yeah.
We thank all the experts as well as panelists and the viewers. We are going to close the show. Thank you all.
Thank you. Good night. Good
Thank
night,
you.
everyone. Thank you, sir.
Thank you. Good night.
Night.
Thank you,
Thank
sir.
you.
Thank
Good
you.
night.